I will be the token medical oncologist talking about some fun things in prostate cancer. So as many of you know, prostate cancer care has become more and more biomarker oriented, and this becomes important over the long natural history of the disease. And certainly we're making a big difference now. We have better therapeutics, but one thing that we're always lanced with as medical oncologists, well, you guys really give us a whole lot of tissue, which is awesome, so that we understand where we start. The problem is the disease evolves over time, and the evolution, trying to keep up with it, is very difficult. The place that, unlike my other colleagues in medical oncology, I can't just biopsy something soft. We deal with bone metastases all the time. The decalcification process strips away a lot of material, and so we're often left looking for something else that can help us get some insights into the disease. Serum PSA, it's all of our best friends, our worst enemies. It gives us some insight into what's happening with the disease, but generally not enough to make some contemporary treatment decisions. So, where we are then is kind of in a position where we need something else. And one interesting place to kind of go is to look into the bloodstream. So the bloodstream itself is filled with a lot of different bioanalytes. And I'm going to talk about a few of them today, including circulating tumor DNA, CTCs, circulating tumor cells, and extracellular vesicles, because technologies are now allowing us to use them in a meaningful way. So cell-free DNA, or cell-free circulating tumor DNA, is probably the most accessible and probably the broadest used thing that we have right now. Many of you know that patients are coming in asking even their PCPs to order tests that will detect all kinds of cancers. So an example of the GRAIL test is up on the right. It detects many things, including prostate cancer. It doesn't really help you figure out how bad the disease is, so typically not what we need for what it is that we do. Identification of targetable biomarkers, though, is becoming something more important and something that seems to be in line with what cell-free DNA can do, at least to some extent, and even the detection of tumor heterogeneity. And then it also seems to have some ability to predict outcomes, and we're seeing this from groups like Foundation Medicine, where their CDX test, which is now even FDA approved. So even ASCO has been and has recognized that in the treatment of advanced prostate cancer, that liquid biopsies are something that we really need to consider and incorporate into practice. So while biopsy material is always the preferred substrate for any kind of sequencing work, in certain settings, especially when a biopsy site is not accessible, a liquid biopsy certainly is a reasonable alternative. So this is an example of how ctDNA has been put to use. So this is a subset of patients on the PROfound study. So PROfound was one of the pivotal studies which really kind of made PARP inhibitor therapy a part of our armamentarium in prostate cancer, particularly for those men with HRR alterations. And in the PROfound trial, there was a subset of patients that did have blood available that went through the FMI CDX. And when looking at the HRR detection from the liquid biopsy alone, we can still see that we get the same kind of separation of curves, showing that we can pick out patients who are responsive to olaparib, which is a really nice kind of thing to have in our armamentarium again. Now, cell-free DNA is nice, but it leaves a lot of stuff kind of hanging because you're only able to look at DNA, and there's still a lot of other material that we think about in the clinic. So CTCs, kind of circulating tumor cells, emerged as a very interesting and exciting field, maybe back about 10 years ago, and there's still a lot of work being done. So I've been working with an engineer over at UCLA, and we developed kind of a suite of tools. So I'm just going to kind of give you an example of how CTCs are used, because we utilized some of the cell surface characteristics in order to isolate them with a suite of nanotechnology-enabled tools. So, this is maybe this is a little easier to kind of understand. So this is one of my patients, a gentleman who underwent prostatectomy, several years back, had biochemical relapse, then had progression that eventually led to liver metastases and then to his death. Now, the nice thing about this unfortunate case is that his liver disease did give us something to biopsy. So along the way, we were able to collect biopsy material along with his blood samples, which we could then sequence. So using that suite of tools, we actually did single-cell sequencing, and then we could actually make a comparison to actually ask the question, does the blood reflect what's in the tumor? And so in looking at that, we were actually able to show that even at the single-cell level, you'll pick up the identity of the tumor, both the primary and the metastases, all the way just by looking at the CTCs. You probably need a few more than one in order to get that picture, and that's we kind of looked to see if we compiled them, if we could approximate the tumor genome, and we were actually getting kind of pretty close, which is an interesting and exciting way to approach CTCs. So this kind of really fueled a lot of our interest in looking at profiling CTCs at a molecular level. So, from another end of our group, Michael Freeman and Sun Young Yu developed this luminal basal classification system called the PCS system. That was based on tissue that was sequenced in the Human Genome Atlas and other sources. We actually converted it to a CTC-based test that we could utilize. And we did the same thing with the PAM50 classifier, which Felix Fang and George Zhao have been using to, again, classify prostate cancers. And we developed a CTC test based on these. So, with these existing classifiers, we saw an opportunity to actually incorporate them into larger studies. So the CTC, PAM50, and PCS was now built into two NRG trials that are utilizing prospectively the PAM50 classifier. So we'll actually have a prospective study with a nice molecular hypothesis based on PAM50 to ask the question whether or not the blood profiling does it well or possibly even better than the tissue in this particular setting. So stay tuned for that. But, the CTCs offer you more than just what's inside of them, because there are other problems we deal with in prostate cancer. So while it's an osteotropic disease, which is well recognized, those of us that deal with advanced prostate cancers, we see something pop up in the viscera, you kind of start having to tell patients we're getting close to the end. So this is data that Susan Holloway put together looking at a series of phase 3 trials showing that liver metastases carry a particularly poor outcome for patients with prostate cancer. So I had a bright young pathologist who's now on faculty over at Memorial who would tell me that he could see which patients were going to go bad. And I said, Jeff, how do you know that? He said, because their CTCs change. So we actually had him test this hypothesis. So using our CTC system, he actually began to measure just the size of the CTC. So this was great. This is old-fashioned medicine. He had a clinical hypothesis, took the simplest observation, and he told me, yeah, when the CTCs shrink, the patients do poorer. Looking at an array of patients that we had, we saw that anything under 8.5 centimeters seemed to correlate with the presence of visceral disease, particularly liver mets, and a poor outcome on the whole. So we took this a bit further, and instead of just looking at visceral metastases, recently we put out a paper in Clinical Cancer Research looking at the impact of detection of these very small nuclear CTCs and showed that it correlated with poor overall survival and poor progression-free survival. In fact, looking specifically at the androgen receptor targeted agents or signaling inhibitors, we saw that they predicted resistance to the ARSIs, and in fact, they emerged through the course of ARSI therapy. So this was almost kind of like seeing resistance emerge in real time. So, people began asking us, so what's happening? What's the biology behind all of this? And so not to get too deep into this, but Michael Freeman, who is one of the biologists I work with, actually had described an alteration in a nuclear envelope protein called emrin that seemed to correlate with more aggressiveness and greater metastatic capacity. And so we asked the question about whether emrin could be measured in circulating tumor cells, and the answer is yes. So this is simple immunofluorescence. The orange panel just to your left shows the emrin in a white blood cell at the bottom. You can see you get a nice kind of ring around it, but in the CTCs, the very small ones, you actually lose your emrin and you lose the kind of like your shape along the way. So we actually then went into the laboratory and said, well, what if we just knock out emrin? I mean, I'm not the smartest guy, but if that's what we were seeing, we wanted to see if we could make it happen. And we actually did. So we knocked out a bunch of emrin from these cells and C4-2B cells and D145s. And we actually saw, when we profiled the cells, that they began to gain kind of this more neuroendocrine or plastic phenotype that's in the bottom left. And then the other cool thing was, when medical oncologists see liver mets, one of the things that we like to reach for is platinum. So over at MD Anderson, they've been using the Cabazzi-Carbo combination, but historically we said, well, if this is a more neuroendocrine or small cell tumor, you use platinum. We actually showed that we could enhance platinum sensitivity by knocking out emrin. So, this biology really seems to be present in the morphology of the CTC. And the biology and the morphology, because Don Coffey taught me these things many years ago, they really go hand in hand. Now, CTCs are great. I'm going to tell you, having worked in that area for a decade, they are a super pain in the butt to work with because you need fancy technology to work with them. They're very hard to preserve. Whereas other things like extracellular vesicles, which Dolores DeVizio is the world expert on, she's a couple doors down from me. Dolores said, why don't you study these things instead? So we used a similar approach to extracellular vesicles by looking at what's on their surface. And we designed, and we thought about comparing them to CTC. So this is kind of a rough way about how I got sold into EVs, and that they're more frequent. You'll find them more often than you will a CTC. You can't do morphology work, but importantly, in a low disease volume setting, you can still find EVs where CTCs get to be really rare, and then my ability to make any kind of statement about the disease gets cut off. So, we got the old slide set. So we actually went through a process of adapting our CTC technology to EVs, and we were able to pull down the EVs that had kind of epithelial surface markers on them, and we're able to profile the RNA in them. And when we did this, we could actually see that we could distinguish localized from metastatic patients, and importantly, over the course of time, we could actually measure the change in the EV burden, which seemed to reflect how the patient was behaving independent of the PSA, which was really nice. But looking at content is nice, but let me tell you, the field is getting a little more directed than that. So with the emergence of drugs like Pluvicto, we began thinking about what's on the surface that we can throw a dart at, whether it's a radionuclide or an ADC or some kind of immune conjugate. And one of the newer targets that's coming forward is B7H3, which is an immune biomarker that regulates some of the interaction with the PD-L1, PD-1 axis to activate T cells. And it's really kind of emerged as something interesting in prostate cancer because it's upregulated in CRPC. So we asked the question, can we detect this in a liquid biopsy? So we actually took a similar approach by capturing B7H3 positive EVs from the blood, and we were actually able to show that in healthy patients versus CSPC versus CRPC, we saw an increase in the amount of B7H3 in the blood that we were seeing. Next. And that, again, it kind of correlated with overall survival. And this data very much mimics what the pathologists have been showing about B7H3 expression in the pathology literature. And then when we asked the question, is it related to PSA, it's kind of roughly related to PSA because it does seem to reflect disease burden, particularly in the CRPC state. But the interesting thing is, as you go through additional lines of treatment, as you would expect, and as the literature would also kind of point towards in tissue, we see an increase in the B7H3 EV population with increasing lines of therapy. And so we took patients actually who were castration sensitive and then reanalyzed them when they were castration resistant. We saw upregulation of B7H3 in most patients. And the fun thing is, with a liquid biopsy, which you can't do, well, you could, but you're going to make people angry. And my friends at MD Anderson, sorry, they don't mind doing this. You can stick a needle into someone several times. It does kind of irk them, but it's easy to draw blood. We draw PSAs on patients every 4 weeks. No one thinks twice about it. We can actually map out the natural history of the B7H3 relative to the PSA, and we actually can get disease characteristics, disease behavior that we're not seeing. So, and with the emergence of B7H3 targeted therapies, we may have a liquid biopsy, which would be usable in the same way that we're using PET scans to pick people for PSMA targeted therapies. So in short, I'll say, patient-centric translational research remains really important. I mean, that's something I think you're seeing a common theme through all three talks that you've gotten. Liquid biopsies are really an emerging opportunity to advance prostate cancer care for men and reflects the dynamic biology of the system. And this can be a nice partner to molecular imaging. For those of you that have been trying to get PET scans, it's getting to be more and more competitive, and there's more pushback because of the cost of the PET agents. Liquid biopsies are actually much, much cheaper. But in the end, in order to figure all these out, it requires team science that will take clinicians, engineers, computational biologists, and translational basic scientists to bring this all together. Next. And the fortunate thing is, I get to work with a whole host of folks. I think many of you see a lot of old friends up here from the surgeons that we work with, but our team at Cedars is actually quite big, covering a lot of different areas. Next. And in the end, while I got to share all of this, these are actually the folks that do all the hard work in my laboratory, in our liver metastasis group, in our clinical group, and across the institution. So I'll stop there and be happy to take any questions that you all have. Thanks for your attention.